Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observation and commentary on the JCO article, Sequential versus Concurrent Trastuzumab in Adjuvant Chemotherapy for Breast Cancer by Edith A. Perez and her colleagues. My name is Kathy Pritchard, and I am a senior scientist and medical oncologist at Sunnybrook Odette Cancer Center and a professor at the University of Toronto in Toronto, Ontario, Canada. I am a medical oncologist specializing in breast cancer and clinical epidemiology. An important update of the NCCTG N9831 trial is published in this issue of the Journal of Clinical Oncology. This study represents one of the pivotal trials in the assessment of the role of trastuzumab in the adjuvant setting and was first presented in May of 2005 as one of a pair of presentations at the American Society for Clinical Oncology plenary session, which included presentations from a combination of the NCICTG N9831 and NSABP B31 trials and the HERA trial of Martine Picart and colleagues. The combined NCCTG NSABP presentation concentrated on the results of concurrent trastuzumab and chemotherapy versus chemotherapy alone, since those were the only two arms of the NSABP study and were two of the three arms of the NCCTG trial. At that time, concurrent trastuzumab and chemotherapy proved highly significantly superior to chemotherapy alone for disease-free survival outcome in a combined analysis of NCCTG N9831 and NSABP B31 trials. While the comparisons between these trials had broken preset interim analysis statistical boundaries and therefore warranted publication and treatment alteration, the comparison with the third arm of the NCCTG trial, that of chemotherapy followed by trastuzumab, had not reached the preset O'Brien-Fleming interim significance boundaries. This updated report of Dr. Perez's important trial raises several interesting issues. She and her colleagues conclude that trastuzumab should be incorporated into a concurrent regimen with taxane therapy based on a positive risk-to-benefit ratio. However, the interim analysis and May 2005 ASCO presentation resulted in a decision allowing patients randomized to sequential trastuzumab to switch to concurrent therapy. Thus, few further data were collected regarding this comparison. In fact, because of a disease-free survival event rate that was lower than anticipated, it would have taken 10 to 15 years of additional follow-up to reach the number of events in these two trastuzumab arms that were originally predicted when the study was written. Therefore, updated follow-up, as presented in this paper, actually provides few further data regarding the concurrent versus sequential comparison. Although the p-value does suggest an increase in DFS with concurrent versus sequential trastuzumab, with a p-value of 0.0216, the pre-specified boundary for significance is never met. Unfortunately, other major trials of trastuzumab in the adjuvant setting compare either concurrent chemotherapy and trastuzumab to chemotherapy alone, as in the NSABP B31 trial and the BCIRG 006 trial, or sequential trastuzumab after chemotherapy compared to chemotherapy alone, as in the HERA or PAX-04 studies. The well-powered HERA trial showed a significant hazard ratio for disease-free survival of 0.76 compared to 0.75 in the BCIRG-006 study and 0.48 in the combined NCCTG and NSABP31 studies published in the New England Journal of Medicine in 2005. The PAX study, while perhaps underpowered, does not show significant reduction in the risk of relapse, with a hazard ratio of 0.86 and a p-value of 0.41 for sequential trastuzumab. These indirect comparisons, like those in the Perez trial, suggest that concurrent trastuzumab and chemotherapy are superior to trastuzumab given sequentially after chemotherapy. To the best of my knowledge, no other direct comparisons of concurrent versus sequential therapy have been reported or are ongoing. There was always concern about the use of concurrent chemotherapy and trastuzumab in terms of toxicity, particularly cardiac side effects. While 3% more patients in the Perez trial completed their planned treatment course in the sequential arm, the reasons for additional discontinuation in the concurrent arm were mixed. Cardiac effects were, however, slightly higher for congestive heart failure, 2.2% versus 1.7%, and for asymptomatic drop in LVEF, 7% versus 4.5% in the concurrent arm. What lessons can we take from these data? It seems reasonable to conclude in clinical practice that concurrent trastuzumab is preferred. One must still recognize, however, that sequential trastuzumab has also been shown to provide considerable benefit in most trials. The discontinuation of the non-trastuzumab arm of this trial was the only choice the investigators could have made. However, discontinuing the underpowered concurrent versus sequential comparison, which had not yet crossed any boundary of significance, seems to have been premature. To have continued the study at least to its original planned completion without changing these arms would have perhaps added at least some additional data regarding this puzzle. We are now left with two trials that show substantial benefit for sequential Herceptin, HERA with its hazard ratio of 0.76 and NCCTG with its hazard ratio of 0.67 for disease-free survival. One that, although underpowered, is not significant, the PAX study with a hazard ratio of 0.86, and two studies, NSABP B31/NCCTG with its hazard ratio of 0.47 and BCIRG 006 with a hazard ratio of 0.75, that show an improved hazard ratio for disease-free survival using concurrent trastuzumab. Unfortunately, we are missing the piece of the puzzle that adequately and directly compares the sequential and concurrent arms. It will be important to follow these patients over time to see whether additional toxicity, such as cardiac damage or failure, occurs, and to update the oncology community concerning these data. Early study closure remains difficult and complex, with competing ethical and scientific priorities. We must continue to develop better procedures in this setting. This concludes the JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.